Now, interestingly enough, the BSG is about to come out with their guidelines, and it's not yet, it's in press, and we couldn't put it into our AGA document because gut wouldn't allow us, but we were able to comment in that article, and this is in summary what the British are going to be doing as of 2010. They're going to start screening at 10 years, and they are dividing up their population into risk groups, which we don't do here. So the low-risk group are going to get colonoscopy every 5 years. Who are the low-risk group? Extensive colitis, but no active endoscopic or histologic inflammation. The colon that looks pretty healthy. People who only had left-sided colitis, or Crohn's colitis affecting less than 50% of the colon. Okay, we can live with that. Intermediate risk are going to come back every 3 years. Okay? These are people with extensive colitis who have mild active inflammation, or they have some pseudopolyps, or they have a family history. And the high-risk group, who are going to come back every year, have extensive disease with moderate severe inflammation, strictures, dysplasia in the past 5 years who declined surgery, PSC, or a young relative with colon cancer. So the BSG guidelines are going to differ now. I think in England, they don't have as many healthcare dollars. We think we have healthcare dollars. Maybe we don't have as much as we thought, but they are going to stratify patients. It's kind of scary to me that they're going to take some patients and scope them every 5 years or even every 3 years. So people sometimes say to me, when do I recommend colectomy? I sort of thought about it and I put it all on one slide. So I would recommend colectomy if there's an endoscopically non-resectable lesion, whether it's flat or raised. If you can't get it out endoscopically, and regardless of the grade of dysplasia, it's got to come out. Think of a sporadic adenoma. If you had a sporadic adenoma that you couldn't get out, got to go to surgery. If there's high-grade or certainly cancer in flat mucosa, that's colectomy. Multifocal dysplasia, I have respect for. Repeated dysplasia on follow-up exams. If there's a stricture in ulcerative colitis, that's worrisome, especially if it's in the proximal colon and especially if it's causing symptoms. With Crohn's, it's a little more dicey, right? Crohn's people often get strictures, so we don't jump to colectomy for Crohn's, certainly. But for UC, be careful about a stricture in UC. Inability to perform surveillance for whatever reason. There could be a stricture, there could be a lot of pseudopolyps. Maybe the patient just can't prep themselves well. Whatever it is, if you can't perform adequate surveillance, you might have to have that discussion about surgery. And then patient's preference. If they can't adhere to surveillance, if you look at all the surveillance studies, the ones that get cancer are the people that didn't show up for 5 years because they put their head in the sand. So in summary, patients with long-standing UC and Crohn's have an increased risk for colon cancer. The risk of dysplasia may be decreasing based on those population studies. Polypoid dysplasia, assuming complete endoscopic resection, can be followed with continued surveillance. A DOM or high-grade in flat mucosa and anything that's endoscopically unresectable should prompt a colectomy. And flat low-grade has a variable biology that we're still learning about but deserves close surveillance. If we have 2 minutes, not even 2 minutes, maybe I could just share with you some of the data that we're going to present at DDW. There's been no study to date that has looked at progression of dysplasia based on the side of the colon that it's sitting on. We know from other diseases like Lynch, like even sporadic literature, where people say that the reason why right-sided colon cancers occur or progress is that they're not seen by colonoscopists. And in Lynch, proximal neoplasia progresses more rapidly. So no one's ever looked at this in IBD. So we took our population of patients, and this was done by Robert Goldstone, who's a Doris Duke student with us this year from Mount Sinai. And what Robert did, working with me and Tom and Noam Harpaz, was to take everybody in our database who had pancolitis. So everybody had equal opportunity to get neoplasia in an area that was inflamed. And he looked at those who had low-grade dysplasia in the distal colon or the proximal colon. Now, the only difference in these groups was that the people with distal low-grade dysplasia, a lot of those lesions tended to be more flat than polypoid compared to the proximal location. But other than that, the groups were pretty comparable in terms of their age, their duration of ulcerative colitis, whether they had PSC, their exposure to 5-ASA, their exposure to 6-MP. And in this last slide, this is what we found. The people who had proximal low-grade dysplasia did not progress very much to high-grade. In fact, there were no cancers in this group. Whereas the people who had distal low-grade dysplasia, that's where we saw progression. 13 out of the 70 progressed. There were 7 cancers and 6 high grades. So it looks as if maybe location of dysplasia in the colon, left-sided dysplasia, might, if this is reproduced in other studies, maybe this goes on to cancer. And maybe we have to intensify our biopsying of the rectosigmoid. The one thing we couldn't be sure of in this study was whether someone might have had a lot of years of left-sided inflammation before their extensive, pancolitis. It's very hard, impossible to know that. Patients don't even know it a lot of times. So it's conceivable that maybe the people with distal LGD had many years of inflammation before their pancolitis. But nonetheless, that's the data. We'll have to see whether it pans out in other hands. So I've said a lot. Let me stop here and entertain questions, and thank you for your attention. Peter.
This is really interesting data. I'm stuck. If you could go back the slide to the table, is it the flatness or the distalness? Because it looks like the distal ones are more flat.
Yes.
I'm imagining maybe the raised ones, if you're able to resect them, you can see in your resect them.
Right. There is an interaction there. You're right. And it is true that the flatness does contribute to the progression. That is right. And actually, we also looked at indefinite. I don't know if I have a slide here. Yeah. When we looked at indefinite dysplasia, we didn't see any difference. Now, I don't know, again, what that means, but there really was no significant difference. They looked as if there might have been a little bit less progression in the proximal. But you're right. I think the morphology of dysplasia is still important, whether it's flat.
If you kind of pull those and say, if you just look at lesions that are both distal and flat, are those even more significantly likely to progress?
Yes. But again, is it the flatness that's outweighing the distal? Yeah. So, yes, Grace.
So, tell us about pseudopolyps. When I think of pseudopolyps, I think of two types. Those are the inflammatory, ugly-looking one versus just the white scar ones. Are you taking off all the white scar ones?
We don't usually touch anything that looks like an inflammatory polyp, it's got that white cap, or it's just sort of erythematous. We don't even, touch those. The number of cases where a cancer actually arises in the pseudopolyp is, you can count on one hand. I think we've seen one case of a high grade or a cancer in a pseudopolyp in the last 10 years at Mount Sinai. So that's rare as hen's teeth. The problem is, it's like a minefield. You have like 1,000 pseudopolyps. How do you know, there isn't an adenoma or a DOM lurking, in that field? And you don't. And it's treacherous.
What I call the inflammatory ones, the kind of red, angry ones.
Ignore those.
The scar ones are really...
I mean, if it looks like an inflammatory polyp, if you're at all concerned, of course, you take one or two out. But it's treacherous, and that's where I think, even the British, who are pretty conservative, if you have, somebody with pseudopolyps, you're going to survey them a little bit more often. The problem is, what does that mean? So you can look in every day if you want. I mean, it's still going to be there, and how do you know, what you're going to find? So it's tough. It's tricky. There are some people who have pseudopolyps limited to one little area of the colon, and believe it or not, it's almost heretical to say this, but sometimes we're actually doing segmental resections in people who have ulcerative colitis. You didn't hear that from me. Yeah, Juanita.
What are your thoughts on, I know it's early, vitamin D and calcium, and we're growing that in terms of medical treatment. And my second question, with the microbiome issue, are people looking at the microbial, milieu in these patients?
Yeah, great. So